Tripathi ma'am, Additional Professor, Department of Pediatrics, KGMU. I would like to welcome you, ma'am, and she will be updating us on the best practices in delivery room. I welcome you, ma'am.
Arpita, is my screen visible? Am I audible?
Yes, ma'am. Yes, ma'am.
So, a very good afternoon to all of you. So, in the second series in the neonatology update, today I am going to present the topic which is very pertinent for the newborn and the for the newborn practice. That is the best practices in the delivery room and update. So I will be taking this topic in the following headings like antenatal counseling, neuroprotective strategies, American Heart Association 2020 and RP updates, resuscitation of preterm neonates, what are the cord care strategies, what are the oxygen targets, and when we are going to stop resuscitation. So we know that the transition from the intrauterine to extrauterine life is the most important and crucial time for the newborn. And any adverse event happening during this time has a significant long-term impact on both mortality and the morbidity of that particular baby. So there is a concept of golden hour, which states that we are practicing all the evidence-based interventions for the term and preterm neonates in the first 60 minutes of the postnatal life for the better and the best long-term neurodevelopmental outcome for the baby. So the care being imparted to the newborn starting, it not only starts at the time of birth, but actually the whole thing starts antenatal preparation to the intensive care, and this is a continuum which we are following to give a better neurodevelopmental outcome, an intact neurological outcome to that baby. So just a slide about antenatal counseling, because the preterm baby births are at rise, and the India contributes to maximum number of preterm deliveries of the world. So the antenatal counseling and preparedness is very, very important. Although there are no national guidelines in India regarding the resuscitation and the age of viability, but as we know that survival of newborn beyond 25 weeks of gestation is uniformly very good in the developed countries, and there is no current guideline in India. So full resuscitation is recommended in any baby who is 25 weeks and above. But it is very important to note that in the centers where the facilities for the premature babies care, like ventilators, like surfactant administration, or there is some problem which is detected in the baby antenatally which needs immediate surgery, like congenital heart defect. So it is best to transfer the mother in utero, and that this transfer plan should be discussed with the parents beforehand. So the latest NRP guidelines were released by American Heart Association in 2020, which are released every 5 years. So in this present talk today, I will not discuss all the NRP, but I will touch important debatable issues which are very important for all of us. So a very important point at the time of delivery is a good communication between the obstetrician and pediatrician. And this has been emphasized by the American Heart Association also. So the newborn requires anticipation and preparation, a lot of preparation by the providers who are trained individually and also as a team. So the effective team behavior such as anticipation, communication, then giving the roles to the people, assignment of the roles, and at the end debriefing is a very important, and this has been emphasized in a big way this time in the 2020 guidelines too. So we have to know the details of the baby, details of the lady who is going to deliver, and just going into the OT or the labor room at the time of delivery will not make the things easy, because if the baby is really sick, we may need a team of 2-3 people, a lot of preparation in the NICU. So actually a beforehand planning is required for that. So there are many studies, I will not go into detail, but these are just the cross-references publishers in the NRP 2020, and they have standardized some risk factors like this 2017 study published in Archives. They have showed that 20 risk factors, there's a group of 10 risk factors, and if they are present, they say that definitely this baby is going to be needing advanced resuscitation. So that in that case, you need to have a full team required so that you can manage the baby in the labor room. So these kind of some checklist is needed in each and every place. and that has to be seen before the delivery. So now I am coming to two very, very important neuroprotective strategies which are important for the outcome of the preterm babies. So in India, many times it happens that the pregnant mothers first report directly to the delivery room and they are not booked in your place. Then in that case, these drugs, they have to be administered by the gynecologist, and we have to inquire and we have to make sure, we have to communicate with the gynecologist at our place that these are really very important and it make difference in the outcome of the small babies. These are antenatal corticosteroid and magnesium sulfate, which are actually a kind of magical drugs. So just a small update that the importance of antenatal corticosteroid was shown by the Cochrane analysis by Roberts d et al., who showed that there was a in this systematic review and meta-analysis in which around 8,000 babies and mother pair was there, and antenatal steroid, they cause a reduction in RDS of about around 40%, 50% reduction in IVH, NEC, need for mechanical ventilation, sepsis, and newborn death, and PPD. So all these are the advantages of the antenatal steroid in this which were shown in this Cochrane review. After that, these recommendations, they came that any delivery which is happening between 24 plus and less than 34 weeks, a single course of steroid is recommended in who are having a risk of preterm delivery in the next 7 days. And which corticosteroid? So the answer is that both of them are equally effective. Dexamethasone 6 mg 12 hourly 4 dose, beta 12 mg 24 hourly 2 dose intramuscular injections are recommended. And there is only one contraindication is frank chorioamnionitis. And what about repeat course? A single repeat course of antenatal corticosteroid should be given who are having a risk of preterm delivery in the next 7 days and who have received a previous course 2 weeks back. So the antenatal corticosteroid, it has a maximum effect if the fetus is delivered 24 hours after the last dose and the whole course is complete, and this effect actually lasts for the next 7 days. But it is shown that in many studies that the partial effect is always there even if just one dose is given to the mother. So it is worth it giving a single dose of steroid in the delivery room in a mother who is less than 34 weeker, who is not having any chorioamnitis, and who is having who is in labor. Then second drug was magnesium sulfate, which is given for the neuroprotection. The indication is for the women with the gestational age 30 less than 31 weeks who are at risk of imminent preterm birth. Dose is 4 gram of loading over 20 minutes followed by a maintenance dose of 1 gram per hour for 1 day or till delivery. And there is no repeat course for this drug. The contraindication is mainly the muscular problems in the mother like myasthenia gravis, myocardial dysfunction, cardiac conduction defect, and in the mothers who are having the CRF, the maintenance dose is usually omitted. So what is the mechanism of magnesium sulfate? So magnesium sulfate actually acts by inhibition of calcium influx into the cells. It also has the anti-inflammatory effect, vasodilatation, and decreases the free radical injury, and gives a decreased risk of cerebral palsy in the babies. So WHO and many obstetrical societies, they have recommended the use of magnesium sulfate in all the mothers who are delivering in the gestational age less than 31 weeks. Now, another very important issue is that we know that the hypothermia prevention is very, very important. But in this, it is not actually taken that due importance. And the evidence is shown in many studies that when the preterm baby is delivered and he reaches to a NICU, the incidence of hypothermia in those babies is as high as up to 78%. And it was seen in this study, which is shown here, that 1 degree drop in admission temperature increases the odds of mortality by 28% and late onset sepsis by 11%. So it is very important to maintain the euthermia, that is a temperature of 36.5 to 37.5 in the babies at the time of delivery in the delivery room. So what steps we can take to prevent the hypothermia? So we know all this, but it is just emphasis on certain things based on the research, that warmer should be on with the manual mode with the 100% heater output for at least 20 minutes before delivery. The linen should be always pre-warmed, so we have to receive that baby in a pre-warmed linen. AC should be switched off. The newborn care should be away from any vent. The delivery room temperature should be monitored, and that has to be kept at least 26 degrees. And the humidification and warmidification of the air which is resuscitating, which is suppose we are giving delivery room CPAP. So that is very, very important. Preterm newborns who are less than 32 weeks, we can directly receive without drying them with a linen. We can directly receive them in the polythene bags or wraps. That also causes the decreased heat loss from the skin, and that has proved that it is very, very effective in the prevention of hypothermia. And also it is very important practice to document temperature in the delivery room, or also when the baby reaches into the NICU, as a quality indicator for the prevention of hypothermia. So these are the poly wraps which can be directly used to receive the preterm babies who are less than 32 weeks and not drying and immediately shifting to NICU in these. So skin to skin contact, we all know that placing healthy newborn who do not require resuscitation skin to skin, it improves breastfeeding, temperature control, blood glucose stability, and mother-infant interaction. So when the baby is born, he is very, very active in the first 1 hour. And that is why the first golden hour concept is there. And after that, the baby goes to sleep. So this active phase of the baby, in which the birth cry is there, relaxation, awakening, activity, rest, then he crawls, then he familiarizes, then suckling occurs, and then he goes to sleep. So many times what happens, we are bothered about the baby only after this golden hour is passed and the baby goes to sleep. So then it's very difficult to make him awake and then to let him feed. So that is why this concept is to keep the baby on the mother's chest between the breast, and then to dry and keep it there so that he starts and initiates feeding in this golden hour. Now I'm coming to important resuscitation point, that we know that this mother is going to deliver. There are certain risk factors. Based on that, the person trained in basic resuscitation, and in case the high risk delivery is there, a team should be available for the advanced resuscitation. So anticipation, team briefing, and role allocation, there should be a leader who will allocate different role to different people to do many tasks. And equipment checks is a very key role for a positive and effective resuscitation. No routine oronasal suction in an asymptomatic vigorous baby, so do no harm. So we don't have to do anything extra. If the baby is breathing well, he has to just put on the mother's breast, skin to skin contact. And the most important step is positive pressure ventilation. The person who is there at the time of delivery should make the baby breathe at 1 minute of life if the baby is not breathing. So rising heart rate is the most important sign for the effective positive pressure ventilation, that will give you a reassurance that the baby is improving with the help of resuscitation. And at the end of the resuscitation, as shown in the American Heart Association NRP, that debriefing is also very crucial, in which first the head person actually applauds the other team, and then actually comes with all the shortcomings of the different person, so that whatever went wrong in this resuscitation is not repeated next time. So that is very important before dispersal. So now in the resuscitation, we already know that about meconium 2015 guideline, they came with a major change that any baby non-vigorous with meconium stained amniotic fluid routine endotracheal suctioning is not recommended, and it is done only if the airway is obstructed. Otherwise, no baby will be routinely intubated. Even the non-vigorous meconium baby will be resuscitated just like a normal baby, and the positive pressure ventilation has to be given. So that was a major change done in 2015. Then many studies are coming up which are showing that two-thumb technique for doing the chest compressions, it achieves greater depth and lesser variability of pressures with each compression rather than with the two-finger technique. So they are always preferred. The neonates with moderate to severe asphyxia, they should be given the benefit of therapeutic hypothermia as early as possible. and within 6 hours of life. Although this facility of therapeutic hypothermia is not available at all the places. And another trial, which is the Helix trial, which has actually come up very recently and published in Lancet, it showed an unfavorable response in this, especially in the developing country. And this showed that it did not reduce the combined outcome of the death or disability at 18 months after neonatal encephalopathy in low and middle income countries. And there were some more deaths actually in the group in which the hypothermia was offered. Although currently the Neonatology Forum, NNF, has not changed any manifestations, and based on this trial, if there is any change, we have to wait for that. So currently the recommendation is to pool the babies if you have a facility at your place. Now I'm coming to the delivery room resuscitators. So we have 3 things by which we can breathe, let the baby breathe. First is AMBU bag, which we were using for many years. Then there is a T-piece resuscitator and flow inflating bag, which we don't use, which is an anesthesia bag. So the difference between the self-inflating bag and T-piece resuscitator is that the self-inflating bag can only give the PIP, that is peak inspiratory pressure, and it doesn't provide any peak and expiratory pressure. And but the advantage of the AMBU bag is that it does not require any gas source and it refills spontaneously. So both the things, they have their own advantage. And the maximum FiO2 which we can give by a AMBU bag without oxygen is 21%, and by T-piece resuscitator is 100%. So the advantage of T-piece is that it can give a CPAP, that is peak and expiratory pressure. So the main problem in the preterm babies is the RDS. So if we are resuscitating a baby who is prone to have RDS, that is a less than 34-week baby, so we should always try to change our delivery room resuscitator to T-piece resuscitator from the AMBU bag. So this is a very important change which we can do to make the babies survive, and the outcome of these babies, they change. And there are many studies, and there is a very good study from Anup Thakur et al., which is from India, and they have done this study in the babies delivering less than 34 weeks. In the T-piece resuscitator versus AMBU bag, delivery room intubations were lesser in the T-piece group, and not only delivery room intubations, later on the invasive ventilation requirement was less in the group which were resuscitated by the T-piece resuscitator. So T-piece resuscitator for provision of positive pressure helps to avoid delivery room intubation and invasive ventilation later in the NICU. So it is a very important device to be used. In fact, the must device to be used for resuscitating a baby who is preterm, that is less than 34 weeks. So AMBU bag with the PEEP valve. So there is an AMBU bag by which we can provide PEEP valve, and there are studies available for them. So this is a study which is published in 2020 in about 417 babies. So they have used the AMBU bag in which there was a PEEP valve is there, and by which some positive pressure ventilation was also given, but there was no difference in the outcome. So the AMBU bag with the PEEP valve, at present, it has got no role actually in the newborn resuscitation, and the NRP guidelines do not advocate the use of these AMBU bags. So these are the kind of these bags, and this orange is the PEEP valve, which provides the peak and expiratory pressure also along with the PIP. Then I'm coming to a concept of sustained inflation. What is sustained inflation? We know that the lungs are full of fluid. So in the initial breaths, we want to give some more inflation so that rapidly that fluid is absorbed. So this inflation means we are giving the PIP for minimum of 5 seconds and more. But the initial studies were promising. However, there is a meta-analysis published in 2020, and it shown that the sustained inflation, when we are giving sustained inflation in the initial breaths in the preterm babies, it actually increased the risk of death in the first 2 days after birth. So this actually is not indicated. Sustained inflation has got no role in the NRP. However, at the time of chest compression, there is a latest study I was just searching, in which they have shown at the time of chest compression in an animal model, they have shown that the sustained inflation is associated with a larger volume delivery, larger CO2 washout, and increased tissue inflammatory markers in the brain. So there is no role of sustained inflation, which is many times written here and there in the NRP. So currently sustained inflation has not any role to do in the newborn babies. This is also a small machine called as SAS, which is an affordable portable machine and infrastructure independent, in which inbuilt battery is also there, and the neonatal CPAP for the short-term breathing support. And not only CPAP, it is helpful in the for the babies who are waiting for the ventilators in the units where there's a lot of babies are delivering, and many babies like in ours are waiting for the ventilators. And then in that phase, the PIP also can be delivered by these machines. So they are the indigenous CPAP, which are made by Inasal Pharmaceuticals, and they are indigenous CPAP made by Indian engineers. So most likely they are coming to in the market soon. So this is also a very good device, especially because it is very handy, less in the weight, so it can be used for transportation also. Now I'm coming to the oxygen. So oxygen, we are very fond of oxygen, giving oxygen to the babies, but there are a lot of problems with the oxygen. It increases the generation of reactive oxygen radicals, nitrogen species. It overwhelms the newborn's antioxidant capacity, damages the many cell components like lipid, proteins, RNA, and DNA. In the term babies with HIE, with acidosis, there is a risk of later on there is a acidosis, and there is a risk of BPD in the preterm babies. Meta-analysis in the term babies showed that if we are resuscitating the babies directly with 100% oxygen, that is, we have applied the reservoir and then we are resuscitating with that AMBU bag, there is a higher risk of mortality in those newborns. So oxygen is very dangerous in that case. And oxygen exposure after hypoxemia, if there is hyperoxia, so it actually increases the free radical damage and reperfusion injury. So we have to really start for particular oxygen, which are the levels given. So for the preterm babies less than 35 weeks of gestation, we have to for the term babies, sorry, it is written wrong. For the babies who are 35 weeks and above, we have to start on room air, and later on we have to titrate as per the minute specific oxygen saturations. For the preterm babies, we have to start from 21 to 30% oxygen. However, when the baby has reached to a state when chest compressions are given, at that point of time, the oxygen has to be 100%. And once the heart rate is again recovered at the time of chest compression, then we have to again slowly reduce the oxygen and it has to be weaned. So these are the targets which are given for the term and preterm babies, which are minute specific. So all the babies while we are resuscitating should have a pulse oximeter in the right preductal side, and from 1 to 10 minutes. So it takes 10 minutes to reach a 95 saturation in a term baby, and similarly it takes 10 minutes to reach a 95 saturation in a preterm baby. So these are the targets. Preterm targets I've taken from the WHO protective guidelines for the preterm, and term from the NRP guidelines. So they have to be targeted. For example, at 4 minutes, if the baby is showing 85, 75, so that's okay for the baby, and there is no need to increase oxygen for that. So these should be stuck at the place where we are doing the resuscitation, so that we can look for the saturation of the baby according to those timings. Then optimizing the delivery room care of the preterm baby. So when a baby who is born, who is extreme preterm, like less than 1000 grams or less than 28 weeks, we have to in early initiation of respiratory support in the delivery room, and this can be given with the help of delivery room CPAP. So if a baby is spontaneously breathing, there is no need to intubate the baby, but the delivery room CPAP can be offered very well by TP's resuscitator, by the mask of TP's resuscitator. Another thing is that the TP's resuscitator should be connected to a blender, so that we are not giving 100% oxygen to that primary, and we are targeting to the minute specific saturations. And after 10 minutes, we will be always keeping, for all the babies, term and preterm, we will keeping the saturations 90 to 95%. So we always need delivery room CPAP, blended heated humidified oxygen. And if we are waiting the baby to be shifted and the baby is in distress and CPAP is provided, and on that the FiO2 requirement is more than 30%, so early rescue surfactant should be given even in the delivery room itself. So there is no role of any prophylactic surfactant in the babies who are extreme preterm and who are having no distress. So the algorithm that providing early CPAP decreases work of breathing. When we give a CPAP, it achieves a tidal volume automatically, and the distress is reduced, and even the surfactant requirement is reduced. So CPAP helps in many ways. The surfactant requirement is reduced, the apnea is not happening, and it also avoids later on invasive ventilation in the RDS babies. So we should have all these things, especially if we are going for a preterm baby resuscitation. So we should have a blender, we should have a TP's resuscitator with us, and we should have a plastic poly wrap to receive the baby, so that we can give PEEP to the baby. We can target for the minute specific saturations in the preterm baby and not the 100% saturation. And we can receive the baby in the plastic poly wrap so that they doesn't develop any hypothermia and they reach with a normal temperature in the NICU. So delivery room stabilization, I have done all this, and there is no role of HHFNC, that is heated humidified nasal cannula, for the management as a first line of therapy in the stabilization of the preterm RDS babies. And it was seen that the requirement of giving surfactant is reduced by 50% if you start giving CPAP straight away from the delivery room while reaching the baby to the NICU. Now I'm coming to very quickly to the umbilical cord management. So cord clamping time has to be minimum 30 seconds and preferably 1 minute. There are many studies. I'm just skipping those studies. Umbilical cord milking, this study was done and it was associated with increased bleeds in the brain in the small babies. So actually it was terminated midway. So cord milk is absolutely no. We have to do delayed cord clamping for preterm and term, both babies, because it gives at least 80 ml of extra blood to the baby. The benefits is for the preterm babies, there is less risk of IVH, NEC, transition circulation improves, and less risk of dying. For the term babies, higher HB at 24 to 48 hours, less iron deficiency at 3 to 6 months, and also it doesn't put the baby mothers, there is no risk of PPH if the delayed cord clamping is done. Nothing has to be applied on the cord, we all know that. Then early initiation of breastfeeding. So especially because I'm emphasizing my talk on preterm, I want to say that the manual expression, in case of the baby is not directly fed because the baby is less than 34 weeks, the manual expression and breast pump expression, and giving even the small amount to begin with on day 1, day 2, day 3 breast milk, it will increase the rates of breastfeeding at discharge. And this was found in our recent study which is done in the NICU, that if the baby is given 100% breast milk in their first feed, they are most likely to be discharged on exclusively breastfed. Then I'm coming to a point that when we are going to stop resuscitation. So in this guideline NRP 2020, they have done a minor change that if all the resuscitation steps are effectively completed and there is no heart rate response by 20 minutes, so redirection of the care, that we have to stop resuscitation. So from starting of resuscitation till 20 minutes, if there is no total 20-minute resuscitation, they are advocating. In the prior guidelines, it was 10 minutes after the cardiac arrest they were mentioning. So the take-home message is antenatal steroid and magnesium sulfate. If it is not happening, talk to the gynecologist at your center. The rate should be increased, because even in very good centers, the complete antenatal steroid coverage is very low, in the tunes of 50 to 60%. Then delayed cord clamping and delivery room strategies by giving resuscitation by delivery room CPAP is very important. Non-invasive ventilation, TP's resuscitator use instead of using AMBU bag for resuscitating the primies, and early initiation of breastfeeding is very, very important. So these are the 5 stars of my talk. If these are the important take-home messages. Thank you very much.
That was an excellent presentation, ma'am. Thank you so much for that. And I would now request you to take few queries in the chat box. Regarding, is there any data on SARS and is it cheaper than the TP's resuscitator?
No data as such. We are just being given these 2 machines, and we are started using those in few of the babies in which there are good outcomes, some bad outcomes also, but not the consolidated data, because we have just started using. But for the low resource setting, I feel it's very good because it doesn't need the electricity and it is very handy. It is just 5 kilo, just carrying like a bag. So transporting from one unit to other is very, very quick and very comfortable with this.
Right. And maybe 1 year down the line, we will have some data to clarify this point. So thank you so much, ma'am.